good afternoon everyone again, and I'm going to talk about the Raindrop inlay. My disclosures are that my ULTRALASE is supported by Vision Optics, and this, as you've heard, is a very small lens, 2 millimeters, 32 microns in thickness, and it differs from the FlexiView in that the FlexiView is implanted deeper, and FlexiView has a refractive index which refracts the light. The Raindrop doesn't have a refractive index. It's similar to the refractive index of the cornea, and it rather creates changes the profile, and in doing that provides a near vision, and it's placed more superficially. So there we go. That's the anterior surface of the cornea to this flap is 150 microns with 100 microns of stroma cushion, not the 300 plus microns or the 200 microns of the camera. And so the inlay is placed. This is a video of how it's done. You've seen femto flaps before. The flap is lifted, which every LASIK surgeon is familiar with. The implant is easily placed over the Purkinje reflex, and you've got to replace the flap carefully, but essentially you will put it back in place. The consistency of that inlay is 70% water, so it behaves like water. You've got to be very careful, you will wash it away, and you won't even know it's washed away because it's hard to see. So you have to do the post-operative check of the slit lamp to see everything is correct. This is how it is inserted. There's Easy Prep is the inserter, which is a titanium little blue metal piece there. There's a little cap on it, and in that little cap is water to keep the inlay hydrated, and that little inlay is sitting at the tip of that blue titanium metal piece. So there's, once you remove the cap, there's an inlay and that tip there, and that's been placed on the cornea. It's a plate, and the little inlay is carefully drawn out of there. The consistency of this inlay is very much almost like mucus. It's like anterior capsules you've dealt with many times. You touch it too hard, it tears and breaks, so you've got to be very gentle with it. And there it is in position, and if you do dilate people, which we don't usually, you can just about see it. It's very difficult to see when you've done the procedure. The advantages are it's reversible, and it's easy accessible implantation, manipulation, removal, because if you've ever lifted a LASIK flap, you can deal with that. Concomitant LASIK is possible, the same interface. It's not visible cosmetically, and it doesn't obscure the retinal cataract view if you happen to need to do surgery on the anterior posterior segment afterwards, and it doesn't require the expensive centration equipment that some of the other inlays require. Our experience is that there are 30 clinics around the UK and Ireland. An optometrist selects the patient and consults them. I tended to meet the patient on the day of surgery, confirm their suitability, and do the surgery and so on. All that has to happen within a 30-minute time frame. The follow-up is done by the co-managed optometrist, and I obviously manage any complications. But the advantage of this procedure is that can be fitted into routine LASIK list. It doesn't add much time to your routine LASIK procedure. So essentially you don't have to change your diary or scheduling at all for this. We did 55 eyes, about equal numbers of males and females, and the mean age was obviously in the Presbymania range. The patient, the follow-up was at least a month, and was done by 3 surgeons under a 150 micron ULTRALASE flaps. All are done on the non-dominant eye. I mean, it's a unilateral procedure at this stage in my hands. The all these patients were near emmetropes, and they all had good vision with minimal astigmatism. In terms of near vision performance, most, as you can see, 93% of the patients were able to see printed newspaper columns and so on. The patients do go myopic, similar to the supercorn Presbymania, so they drifted a little bit myopic, and that tended to stay similar. It didn't seem to shift much over the period of the follow-up, even up to 9 months with our patients. Sorry, that was the visual acuity was slightly reduced because of the myopia, so there's the myopic shift. If you depict the 20-25 line, you can see the uncorrected distance uncorrected near visual acuity, which the red line is very good. Patients are happy with their near vision. Uncorrected distance visual acuity in the treated eye is reduced a bit because of the myopic shift. So for instance, the 20-25 line, you can see that not even 40% of them had 20-25 vision, but of course we're binocular creatures, so the patients did have benefit of the binocular vision. This is a bubble plot. The visual acuity and the distances on the vertical axis and the near visions on the horizontal axis. Preoperatively, all the patients have good distance visual acuity but poor near visions after the top left-hand corner. And each bubble represents a number of patients. So if you have a small bubble, it's a small number of patients, big bubble, a big bunch of patients. And of course, after a month, they've shifted all towards the top right, which is good. There are a few patients with reduced distance acuity, and that's because they've got a myopic shift. And at 3 months, at their last follow-up, which included up to 9 months post-operatively, they were up in the top right-hand corner. There were some patients, which, as you can see, are outliers. And this is because some of the patients developed a condition called haze, and this was an old treatment protocol which has not since been modified. But this haze does induce more of a myopic shift, and of course the haze and the myopic shift affects their distance and their near visual acuities. The complications of this procedure was one patient develops an infection. It was at the edge of the flap, not near the inlay, but at the edge of the flap, and this was related to a blepharitis, which was treated with routine antibiotics and settled quickly, and the inlay has been left in situ. The patient's very happy with the result. And so the blepharitis, the infection was not related to the presence of the inlay. The surgery was, and the blepharitis implicated. The haze, a fairly high proportion of haze with a trace of it. I mean, anything that, any one of the following optometrists who noticed the slightest bit of any variation in the clarity of the cornea was documented. It was significant over the period of the follow-up, which was up to a year afterwards, was 23.6% with an older treatment regime, and 1 to 2 lines of acuity were lost. The patient was treated with topical steroids, and all of these resolved, and except 2 of the patients, the haze did not resolve, and in these 2 patients, the inlay was removed at the patient's request. The reasons for patient dissatisfaction, there are 3 patients really who have been highlighted to me as surgeon following all these patients now. The first patient, her expectations weren't met for distance and near vision. She said it seemed to be mainly her near vision she complained about, and I then offered her the options, which were to leave it in situ or remove it and to give her monovision. And she actually said she wanted her money back. And I think that's been the main motivator for her complaint. I think it's less to do with the complaint about the inlay, because she has asked to keep the inlay and she doesn't want any further surgery. And she was actually seeing her phone and reading quite well out in the waiting room. And when she came in was when she complained. The other 2 are men. The second patient, he wasn't tolerant of monovision preoperatively, and so the criterion for implantation, the patient must tolerate monovision. And he was told at the consultation by another colleague's co-manager that his distance vision would be better than was shown with the monovision. So he went ahead with it, and it was similar to the monovision. I think he was ISO 50, and he said, even though I appreciate the near vision benefits I've got, I still am very frustrated with my distance vision in that I'm aware of the blur all the time, and he says himself, I shouldn't have had this in the first place because I didn't tolerate the monovision. So he has had it removed, and he's very happy, very easy to remove. And the third patient was a patient, also a man, who wasn't very compliant with medicine, and medicine is important because if you don't take your steroids as recommended, you get a high incidence of risk of haze. He developed haze, his distance vision was affected, it troubled him significantly. His near vision was also affected a little, but he still had pretty good near vision, better near vision in the eye with the haze than in his untreated eye. Yet he asked for the inlay to be removed because of the frustration with his distance vision. And he's very happy now, been removed, very happy, settled down very well. So it's very easy to reverse and to remedy if the patients are unhappy. So I have 10 tips of success or lessons that I've learned. Again, a good old one of good patient selection. And the critical one there is monovision tolerance. Patients need to be counseled, they need to be realistic distance vision and near vision expectations. And the counselling has to be documented very well, so if there are complaints later, you can say we did talk about this. You need to optimize the ocular surface preoperatively. The patients with blepharitis or bony gland dysfunction or severe dry eye needs to be optimized, or they need to be refused the surgery. They need to have good flaps, and I've had very good success with the ULTRALASE doing the flaps for these patients. Now the easy prep cap that's just depicted in that photo on the right has to be very carefully removed, because when you remove the cap you sometimes remove the inlay and you don't see the inlay, so you throw away the cap and you throw away the inlay and there's nothing to implant. So that little cap is filled with fluid, and you have to aspirate the fluid with a little syringe, and there's a blue titanium holder, a little plastic cap, and there's another metal bit sticking up out of it. That's actually an aspirating little blunt needle where you aspirate the solution from the saline solution from the inside the cap. And that whole process has to be done carefully, or you will remove the inlay. And then you need to center the inlay carefully and gently manipulate, because you can tear it. And if you don't center it carefully, obviously there will be optical aberrations, and the patient won't be happy. And you can decenter by up to 0.5 millimeter asymptomatically, but beyond that you need to go back and replace the inlay. The flap replacement technique is critical, because usually when we replace a basic flap, we do a lot of irrigation underneath it. We dab and we wipe and all that sort of thing. You can't do that with this. If you do that, you'll wash away the inlay. So there's a specific technique, and you need to be trained to do it, because otherwise we'll have no inlays and lots of perfect flaps but nothing else. The patients must be encouraged to have good compliance with drops, and they're not particularly bad. And they need to comply with the drops for 3 months, and they need to really stay on the steroids. And every follow-up appointment, you need to remind them to do that. And there's an issue with the haze. The new treatment regimes reduce the incidence significantly, but the haze is reversible, and it's associated with a myopic shift. So if a patient presents with a myopic shift, they've been about -0.50, they've dropped down to -150, even if there's no haze, treat it as though there's haze, and the myopic shift will reverse, and the haze won't develop. But if they have haze or myopic shift, you need to treat that. So those are my 10 tips for success. And in terms of patient satisfaction, again, the criteria I mentioned in SuperQuad, similar to CBB, means couldn't be better, pleased with the results, is PWR, and satisfied is 20%. So overall, 96% satisfaction rate. None of them regretted having had it, except possibly a woman who wants her money back. I think she's regretting having paid, not having it in there. And 4% hope for better.